Good afternoon, everyone. I am Sela Panapasa, Associate Research Scientist at the University of Michigan's Research Center for Group Dynamics at the Institute for Social Research, and will serve as moderator for this session. I wanted to provide you with a few housekeeping items before we get started. If you hold MCHES status and did not submit your ID number during registration, please submit your name and ID number to the email address shown on your screen to receive your credits no later than tomorrow, September 18th, using the same email address used to register for the symposium. All virtual symposium attendees have been placed on mute. Please post your question through the Q&A corner icon at the top of the screen for responses from the speakers. Due to limited time, not all questions will be addressed during the symposium. Finally, we encourage you to answer the 2-question survey that will appear on your screen following this presentation. It is my pleasure to introduce Johnny, aka Chip Allen. Mr. Allen currently serves as the Director of Health Equity at the Ohio Department of Health. In this position, Mr. Allen is responsible for developing agency-wide goals, objectives, and strategies to eliminate health disparities and promote health equity for all Ohio residents. Additionally, Mr. Allen works in partnership with national public health organizations, state cabinet level agencies, and a variety of public health programs to target services to disenfranchised groups, measure program performance, and assess outcomes. Our second speaker is Stephen Thomas. Dr. Stephen Thomas is founding director of the Maryland Center for Health Equity and professor of Health Services Administration in the School of Public Health. Dr. Thomas is one of the nation's leading scholars on community-based interventions to eliminate racial and ethnic health disparities, including obesity, diabetes, hypertension, HIV/AIDS, and violence. He is principal investigator of the Center of Excellence on Race, Ethnicity, and Disparities Research, funded by the NIH National Institute on Minority Health and Health Disparities. Since 2015, he has been supported by the Cigna Foundation with a World of Difference grant that supports the mobilization of Black barbershops and salons to become portals for delivery of medical and public health services. The objectives of this session: what data tell us about COVID-19 in racial and ethnic minority communities, are to provide background and context about the disproportionate impact of COVID-19 on racial and ethnic minority populations, as well as tribal and urban AIAN populations, using the latest data, and to discuss the importance of and recommendations for collecting and using race, ethnic, and tribal data to ensure equitable response. Without further ado, let's get started.
Thank you very much for that kind introduction. I'm pleased to share with your audience here some additional information. There will be things that I say we may not agree with, and I'm hoping that we really begin a robust conversation on these topics. because advancing the response to COVID-19, sharing promising programs and practices for racial and ethnic minorities is indeed vitally important. And what data tell us about COVID-19 and racial and ethnic minority communities should give us the urgency of now. This is the one slide about our Center for Health Equity. Our motto is building bridges, building trust, building healthy communities, and around the edges there you see all the ways in which we get off of our campus and into the neighborhoods where the actual health disparities exist. You know, racial and ethnic health disparities have existed ever since we've collected health data. And it's really, I think, important to acknowledge the fact that COVID-19 has truly exposed the deferred maintenance of our public health infrastructure, the challenges of our healthcare delivery systems in addressing these underlying conditions, many of which are totally preventable. And it is my hope that we will rebuild in a way that addresses these disparities that have been identified through COVID. And I come at you really from the spirit of the civil rights movement. I do that because it is the one area where we have evidence that we truly have had social change. Social change has come from social movements, and the civil rights movement is one of them. And I think one of the things to take away from the experience is that we must really move beyond the biomedical model. If COVID has taught us anything, there are factors such as poverty, factors such as access to quality health care, exposure to environmental hazards in homes, that are factors that are outside the biomedical model that must be addressed. And COVID has exposed that. COVID has also exposed the need to actually tailor our messages to the community we're trying to reach. So it's not just the message, it's also the messenger. And one of the things that we've learned is to recognize that in addition to COVID-19 and the disruption of our economy that has occurred, the unemployment, the pain and suffering, the death, the people unable to mourn their loved ones because they can't be present, there are other voices from our history that I think we should listen to. And that's Frederick Douglass, whose statue is at a library, in front of a library on the University of Maryland College Park campus. And Frederick Douglass said, and I say this to emphasize, what is the context driving these health disparities? Frederick Douglass said that if there is no struggle, there is no progress. Those who profess to favor freedom and yet depreciate agitation are men who want crops without plowing up the ground. They want rain without thunder and lightning. They want the ocean without the awful roar of its many waters. And I would submit to you that the protests that we see in the streets, and they've been going on daily in parts of the country, in Portland, in Kenosha, Wisconsin, in Rochester, New York, that's the awful roar of the many waters, changes in the air. And I think it's important for us in the health arena to take advantage of this moment to reimagine how we come back better than what we were before the pandemic. And so I'm hoping that we can agree on some things when we talk about health disparities and health equity, namely that health equity means that everyone has a fair and just opportunity to be as healthy as possible. Look at what we're seeing right now. Right now, everyone does not have a fair and equal opportunity even to get a COVID-19 test. Everyone's not getting a fair and equal opportunity to get personal protective equipment. These are all factors that COVID has exposed that we must address. I place them in the health equity arena. And we also must recognize that the data I'm about to present can at times numb us to the fact that these are brothers, sisters, fathers, mothers, grandparents. These are loved ones in these data. And so they're changing every day, but unfortunately the trend continues that we continue to have a disproportionate burden of COVID-19 deaths and infections in the United States, now let's just take the entire country relative to the world, let's say the industrialized world, the modern world that we compare ourselves to, and that in this country, racial and ethnic minority populations have a significant disproportionate burden from this disease. And all of that has been attributed to what's being called these underlying conditions. So it is not because Black people are Black biologically, or Hispanic, or Latinx, or Native American population. It is not because of their biology. It is because of the way they're treated in our society that places them at increased risk for COVID, places them at increased risk for exposure because of the jobs they have, places them at increased risk because if they're not working and they can't work from home, they must be out and therefore potentially exposing themselves to the virus. So the data is, I guess it would be easy to ignore if it were not so well documented. But be mindful as you look at this slide. The New York Times had to sue the federal government, a lawsuit. They had to take the government to court just to get the data broken down by race. There's been statements that we would have this for information across the nation. That has yet to happen. And so we still have a patchwork of race-based data being presented. And the striking racial divide on how COVID has hit nursing homes is another example of, I'll call it rankism. We've been praising the healthcare workers, but that has not extended to the workers in our nursing homes and our extended care facilities. I think that's important. We're looking at inherent biases that we must address if we're ever going to solve this problem. And here's another example. This is the U.S. rank among nations hit hardest by the virus, and 10 states outrank all of them. This is just really embarrassing. We should be ashamed because we actually know what to do. And why it's not being done is why we're having this conversation, and what I hope will be a very robust discussion. And so those are all real people in those numbers. And folks, be mindful, we're talking about just a matter of months where COVID-19 has become, one of the top leading causes of death in the country. And we're just talking since maybe February. So, where do we go from here? This was a question Dr. King asked at the height of the civil rights movement. Where do we go from here, chaos or community? And what we are seeing is that we see a lot of chaos out there. We see people getting into fights over the very things that can protect us. In this image on the top, what works is trust. And that's me standing there with two barbers that we work with in our network called HAIR, Health Advocates in Reach and Research, a network of Black barbershops and beauty salons where we bring health services to the community, where we help educate the community about COVID-19 mitigation, where we make it okay to wear your mask, where we make it okay and help people understand why 6 feet away is so important. But here's what doesn't work, and that is the disinformation being disseminated in Black and Latinx neighborhoods. This is a flyer sent to me by one of our barbers, and it basically says COVID's a hoax, don't take the test, don't take the vaccine. And I've got real concerns that we are not responding quickly enough to this disinformation that's taking hold in our communities. And it means all the more that we get out into the neighborhoods with trusted partners. We need to work with people who already have trust in the community and ensure they have accurate information about COVID-19 mitigation. And so that's what we have attempted to do in our efforts here. We have established the Colors of COVID-19 Consortium for Prevention, Detection, and Treatment of Black and Latinx communities in Maryland and across the nation. Our whole effort here is to make a difference where we live right here at home and make that resource available as a model across the nation. And as you can see, state COVID-19 data by race, which states have released data by race. That may change over time, but it is really appalling to me that we still do not have a national release of data by race and zip code, which would enable us to pre-position resources to where we know the virus is coming and where we know we will have issues once flu season starts. So I think we need to think of this, yes, it is a health crisis, but maybe the mindset that would help us is to recognize that it's like a natural disaster, a flood, fire. When we think of those things, pre-positioning resources is natural. It's what we would normally do. We need to think more like disaster preparedness. And it's in that context that in our work, we have built a modular index for tailoring our efforts around COVID-19. This is a database that allows us to generate what we'll call neighborhood risk profiles, a very powerful tool, but again, it's only a tool. These mapping tools allow us to pinpoint where the problem is, but if we don't follow our own data with resources, then we're simply stigmatizing the very neighborhoods. I think that we have to follow the data with resources. And it's in that context that, again, the mapping tools can be very, very powerful. And these slides here, I'm going to move fairly quickly, simply show that there is indeed a relationship between exposure to COVID and racial inequalities. Your audience knows this. The question is, what are we going to do? What are we going to do once we have this level of detail about the nature of the problem? How do we act? How do we get out there to rebuild trust? Who are our community partners to do that? And how do we counter the disinformation that's being disseminated, literally as I speak? And so again, this is the data that we know we have, we've been generating it, and the community is saying, they would say to us, given that you know all this information, why aren't you doing more to protect us? And so it's in that context that history matters. And I wouldn't raise this example if it were not already raised in the context of COVID in the front pages of our newspapers. I think Tuskegee syphilis study is not the only example of research abuse, but it's the one that is most salient as an example of why African Americans in particular and many others have mistrust our healthcare delivery system and our research enterprise. As you can see here in the slide on the left, these are public health service physicians literally drawing blood in the field, out in the neighborhood, and this happens to be a plantation field, making what they do mobile. And on the other side, you see the incentive, burial insurance. That was an editorial cartoon that ran in 1972 when the study stopped. By providing the men burial insurance, they were able to get permission to do autopsies. Let's talk about this when we get to the discussion session. And let's also acknowledge that on May 16, 1997, President Bill Clinton apologized to the survivors of the Tuskegee syphilis study. At the time, there were 8 men still left living. And as you can see in this, President Clinton was not alive in 1932 when the study started. We need to move towards atonement, which means making things better. And that is my hope for our discussion here today and what comes next. And as I head to the finish line here, let me just show you what some of the engagement activities that we work for look like. Here's what community engagement looks like where I live, and that is bringing health professionals, yes, into the Black barbershops and beauty salons. And here's what they're telling us: no research on us without us. I think that's noteworthy. And last but not least, an example of bringing COVID-19 FDA-approved saliva tests into the barbershop. Let me stop there and welcome my colleague, my fellow Buckeye, Mr. Chip Allen. Thank you very much.
Well, thank you, Dr. Thomas, for the wonderful presentation. I agree with the things that you said in your presentation. The history part is so important, and we need to move forward. Again, I'm Chip Allen, Director of Health Equity at the Howard Department of Health and also a member of NASAM. What I'd like to do is talk about how we can leverage data that we have available right now to actually respond to the COVID pandemic that's afflicting the world. And so in terms of just the objective, I'd like to really kind of talk about what data sets are available. I want to talk about how can we, even if you're at the state health department or local community-based organizations, can identify high-risk populations for COVID-19 through underlying conditions, and then also talk about how we can work together either within states or in our communities to actually identify those communities that need our help the most. And so when we start thinking about how do we respond to the pandemic, the president of NASAM, Ms. Vivian Lashley-Bibb, said something that's very important in a letter that she sent to many of my colleagues around the country. And she said that the COVID-19 response falls short of serving the needs of marginalized communities. We, no matter who we are, in this case it could be you or anyone in a leadership position, we have to raise the awareness of our state health officers or who's ever running the COVID-19 incident to be able to offer solutions to overcome the weaknesses that we sometimes find in our department. And so one of the things that we partnered with at NASAM to provide this information is we actually talked about free online data sets that's available to everyone who's viewing this right now. The Social Vulnerability Index from CDC, 500 Cities Project, CARES Engagement Network, and ArcGIS Online. And the reason why we actually want to provide this as a guide, because there's a lot of data inequity. That is that many folks who need the data to respond to issues don't have it. These tools help overcome that. So for example, in the CDC Social Vulnerability Index, it tells you what communities are less resilient to actually be able to survive a human-caused or natural disaster. When we start thinking about the 500 Cities Project, it actually has data on underlying conditions for COVID-19 that would allow you to respond to those conditions at the census tract level as opposed to maybe the zip code level. We actually have the CARES Engagement Network that actually has a lot of data right at your fingertips, hundreds and hundreds of data points that will allow you to identify the neighborhoods that need the most help. And of course, ArcGIS Online. They actually have a free version of this that will allow you to work with many different data sets at one time. So why is this important? Well, one of the things that we've done, and I want to focus on one of our great cities in Ohio, Youngstown, Ohio, is we asked the question, where does kidney disease, asthma, heart disease, high blood pressure, diabetes, and COPD exist at their worst levels at the same time? Sometimes you might hear this called Convergence Analysis. And actually, when we actually took this data, put into a GIS program, and mapped where were all these conditions at their worst levels at the same time, we were able to identify these census tracts. And then when we started to actually look at who was represented in those communities, we see the races that we have here. Now keep in mind, this is based on the data that we have. And so we were actually able to see that in these communities, the overwhelming majority of the population is African American, followed by whites or Caucasians, and then two or more races, about 5%. The Latinx community is about 5%, and 11% of the population was over 65. Think about it. 4,687 people at increased risk based on their underlying conditions for COVID-19. And then when we actually found out how to do this work, it was not only good enough for us at the health department to understand exactly what these issues were, but we knew that we had to share this knowledge and expertise with our local partners. So what did we do? So in this case, this is an example of what we call the Convergence Analysis and also the Social Vulnerability Index. So what we did is we took those two data sets that I showed you, and we actually tried to figure out where were those chronic diseases at their worst levels at the same time, coupled with where those neighborhoods where the highest vulnerability existed. We actually see where there's this connection. It's also interesting to note that when you look at this particular slide and that general shape of those areas that are the most vulnerable in terms of the social vulnerability index, if you were to go and take a map of those homeowner loan corporation maps, redlining, you would see that that is basically the same shape that we redlined. So the areas that have the highest social vulnerability and also that convergence tend to be those areas that were redlined in the 1930s and 40s. And then when you start looking at this information, this is Columbus. We were able to show convergence, that is areas with the high social vulnerability index, and also with a lot of diseases, they tend to be in the same area. We went one step further. We went and did the same analysis for our partners in Dayton, and we were able to show them areas that they needed to pay attention to. And not only did we just stay within our city, we also wanted to share the knowledge with our friends across the country. So I was able to work with my friends at the Michigan Department of Public Health. We were able to share with them this analysis based on Flint, Michigan. Again, it's not enough to have the skill sets to do this. It's important to share with those who are also dealing with the same problems. And our friends in Michigan have done a really good job at using this data to make decisions. So in all of this, what did we learn in just doing all of this analysis? Well, a couple of things. When we took that methodology and actually tried to figure out where were those underlying factors at their highest or worst levels, look at this. In all the cities, you'll see that the majority of the population that actually have been impacted in terms of the worst levels with these underlying conditions, which could be a proxy for where we would see COVID-19. The majority of these individuals, these areas, are overrepresented by Blacks or African Americans. And so not only are we actually seeing a disparity, but because of the systemic nature of what this is showing, we're also seeing an inequity. There is no natural reason why in this analysis African Americans should always be overly represented in these areas. And so it was something that struck me in terms of what Dr. Thomas said, which was true. And this is not an issue of biology. This is not an issue that certain minorities are biologically flawed, and so we have these diseases. It is because of something else that's going on. And what is that? Well, we actually have a tool at the Ohio Department of Health called the Health Opportunity Index. We were actually introduced to that by our friends at the Virginia Department of Health, and then they worked with us to adapt it to Ohio. And we did this analysis. The Health Opportunity Index allows you to understand by census tract which of those social determinants of health are actually working behind the scenes to drive all these issues out of control. And in most cases, when you look at these different cities and what we found, concentrated poverty and income inequality tends to always show up. So when we start thinking about these social determinants, we can see not only is there a systematic nature to some of this, particularly in terms of concentrated poverty, but the thing that we didn't say, which is also underlying a lot of this, is racism. And we have to acknowledge it to be what it is. So one of the things that we also did is I had the opportunity to work with many of my partners inside of my agency, and they identified a new data source that will allow me to understand exactly what was going on relative to those communities most at risk for COVID-19 at the household level. So we started working with the data team that comprised from individuals from Children's Hospital, the Ohio Commission on Minority Health, the Kerwin Institute at the Ohio State University, and a number of other partners. And we came together because we knew that with this new data set that I was actually being exposed to, I needed the best minds possible to help me think through how to best use it. And so then this is what we saw when we went there. We used this data, and we were able to answer key questions about COVID-19. For example, not only what were the households with these underlying conditions, but if there were a secondary wave of the pandemic, what would it hit? Where should we actually be concentrating COVID-19 cases? Testing, so that we can begin to get ahead of the problem. And also, we wanted to understand if indeed we had to equitably distribute personal protection equipment, or even if we wanted to think about where to concentrate vaccine distribution once it becomes available. We came up with these questions, and then we used data to help answer. So, for example, in the slide that you see now, we worked with our Ohio team as well as our Deloitte partners, and we came up with this map that looked at a couple things. So, for example, the triangles that you see, they represent the census tract that had at least one testing site. And then the blue dot represented those individuals who are at risk for COVID-19 based on some of the data. And then the color gradient allowed us to understand the growth rate. One of the things that you would see if you had a chance to really examine this map is that there are a lot of blue dots representing folks who are vulnerable for COVID-19, that there are no testing sites available. And what I mean by vulnerability, we mean the individuals that have at least one of those complications for COVID-19 at the worst levels, and also those households that have incomes less than $20,000. And so we were able to go down to the neighborhood level to determine where we needed to focus. What I mean by the neighborhood level is that we were able to give this type of map to our local partners. So here you see Franklin County, which is houses of the city of Columbus. And then you actually see census tracts where we can tell you where these vulnerable populations are. And because we want to protect the confidentiality of those households, we can only tell you what street that we need to focus on. Plus, we can tell you the demographic nature of the households in those areas. We believe that by actually having this type of information, we can better respond to COVID-19, not in an equal way, but an equitable way. And I think that Dr. Thomas did a really good job of going over those key health equity concepts. So as I am ending my slides and look forward to the questions. Okay, so in terms of the parting thought, the first thing is we have to change the way we think about health disparities and health equity. It is not just an academic exercise. We are all in this together. But for example, what does health equity look like in terms of a response to COVID-19? Do we give everybody the same exact intervention, hoping that somehow or another things are going to get better? Or do we give people who are in the most need what they need to really thrive? Are you at the table in terms of being able to offer solutions to this pandemic, or are you looking in? And if you're looking in, it says something about the structure that we actually have to operate in. You see, organizations and systems are designed to operate exactly like they operate. And we have to be able to change our thinking and to redeploy resources to be able to make equity, health equity, a true reality. Also, we have to keep the faith that we can overcome these issues of health inequities relative to COVID-19. And what that means is we have to share what we know. We have to be able to give of ourselves and begin to challenge those old way of thinking that stop us from actually reaching our full potential. And remember, when I looked at this slide, it's not just about me or you. About a year ago, we were really concerned about the opioid epidemic. and we still need to be concerned about the opioid epidemic. But if you start thinking about these other issues that we have to deal with, right? Homicide, heart disease, substance use, infant mortality, HIV, all of these things are just as serious now as they were before COVID-19. Now we're adding COVID-19 to this. And so we have to really work all together. So thank you so much for listening and looking forward to the question and answer session.